Hi, my name is Jason Bartlett, an ACP with the Queensland Ambulance Service, Brisbane. Today I'm making an exemplar video on laryngoscopy as part of the assessments for PAR 4430. There'll be several parts of the presentation. First I'll introduce an acronym, the LEMON acronym for assessing a patient airway. Then we'll go through the actual physical process of laryngoscopy, including preparation of the equipment and the laryngoscopy procedure.
Common mnemonic used when assessing a patient's airway prior to laryngoscopy and intubation is the LEMON mnemonic. LEMON mnemonic is made up of 5 components. Not all of them are extremely useful in the pre-hospital environment, however it's still a good acronym to use to remind you about a good way to assess a patient's airway. First one is to look at the external facial features of the patient that you're about to, whose airway you're about to manage. Things to indicate that you may have a more difficult laryngoscopy or difficult airway to manage include abnormal facial shapes, sunken cheeks, patients without teeth, patients with large advanced protruding teeth, patients with a shortened mandible, patients who have a narrow mouth that are unable to be opened effectively. Of course, your extremely obese patients or patients with large breasts. This also may include pregnant patients. And then you've got patients that just have unusual facial or neck pathology such as goiters or potentially trauma. The second part of the LEMON mnemonic is to evaluate the 3-3-2 rule. First part of this is to assess how many fingers you can fit between the forward incisors. 3 fingers is a normal anatomical space. If you can fit 3 fingers in, there's a chance that you'll also be able to fit a laryngoscope or an ET tube. Secondly, measure the distance from the hyoid cartilage to the mentum, or the hyomental distance. Less than 3 fingers may indicate difficulty in displacing the tongue forward during laryngoscopy. And the third component is to measure distance from the floor of the mouth to the top of the thyroid cartilage. Anything less than 2 finger distance may indicate that you have an anterior, high anterior cords that may be difficult to view and intubate. The third part of the LEMON mnemonic is to assess the Mallampati classification, or the Mallampati score. Mallampati score is determined by visually assessing the anatomy of the oral cavity. Specifically, it's using the visibility of the base of the uvula, the forcial pillars, and the soft palate. A Class 1 Mallampati, you have full visibility of the tonsils, the uvula, and the soft palate. And a Class 2, you can visualize the hard and soft palate, the upper portion of the tonsils, and the uvula. In a Class 3 Mallampati, you can only visualize the soft and hard palate and the base of the uvula. And in a Class 4, only the hard palate is visible.
There's 2 types of blades available to use for laryngoscopy. We've got the curved Macintosh blades, which in the QAS we use for adult patients. We have these available from size 4, 3 and 2 for adults, and a size 1 for paediatrics. We also have Miller flat blade laryngoscope blades, which we solely utilise for paediatrics, and they're available in a size 0 and 1. The main difference between the Miller and the Macintosh blades is the mechanism with which they're actually introduced and with which they displace and visualise the glottic opening. So with the curved Macintosh blade, we displace the tongue in a left to right sweeping motion, insert the tip of the actual laryngoscope blade into the vallecula, and then in an anterior motion we displace the glottis and visualise the glottic opening. The Miller blade, however, we actually use the tip of the Miller blade to lift the epiglottis and visualise the glottic opening.
The different points of insertion for the Miller and Macintosh blades can be seen in this graphic.
So the goal of laryngoscopy is to get a clear and the best possible visualisation of the cords to allow first pass of an ET tube. So this will be a preparation set up for an intubation according to QAS protocols. We have bougie, all intubations through the QAS are done by bougie. We've got our ET tube, we've got a 10mm syringe ready to inflate the cuff. We've got a bag valve mask, we have suction ready and available We've also got a rescue airway in case of a failed intubation, which in this case would be our LMA Supreme. So I'll now give you a practical demonstration on how the process of laryngoscopy. So preparing the patient for laryngoscopy, the ideal position if there's no cervical considerations or no cervical anatomical complications is called the sniffing position, in which we use head to jaw thrust, which gives us the best alignment of the oral, pharyngeal and laryngeal axis and facilitates the best view of the body opening.
The alignment of the pharyngeal and the laryngeal axis can be seen in this graphic with the patient on the right hand side in the sniffing position.
In the event that we have an obese patient, patient with large breasts, pregnant patient for example, sometimes to facilitate the best view of the body opening we have to use what's called the ramp position, which we do by padding up underneath the shoulders and underneath the occiput, keeping the face parallel to the ceiling. The ultimate objective is to line the ear with the sternal notch with the face parallel to the ceiling.
The ramp position with the alignment of the different axes can be seen here in this graphic.
In pre-hospital environments, most laryngoscopy and intubation will happen either on the ground or on the stretcher in the back of an ambulance. If there's no cervical considerations, we place the patient in the sniffing position, pre-oxygenate with the bag valve mask to ensure maximum oxygen reserve. Have a laryngoscope with the appropriate size blade, spare laryngoscope blade, one size smaller, spare handle with a working light and our intubation equipment prepared and ready to go. Take the laryngoscope in our left hand, insert into the mouth, sweeping the tongue in a right to left motion until the Macintosh blade engages in the vallecula, and then in a forward and anterior motion lift up the laryngoscope to facilitate visualisation of the glottic opening.
Once the glottic opening has been visualised, it is given a grade based on the Cormack and Lehane classification. Grading is rated from grade 1 through to grade 4. In a grade 1 view, most of the glottis is visible. Grade 2 view, at best, half of the glottis is seen, and at worst, only the posterior tip of the arytenoids can be visualised. In a grade 3 view, only the epiglottis is visible, and in a grade 4 view, no laryngeal structures at all are visible. Grade 3 and 4 Cormack and Lehane classifications may indicate a difficult intubation.
Once you've obtained a view, it's important to let your partner and your colleagues know what grade view you have, as if you have a difficult view, it allows your partner to potentially apply some external cricoid pressure or cricoid manipulation to try and assist you visualising the glottis.
That concludes my video presentation. Thank you for listening.